Assalamu alaikum. Today's topic is ventilator. When using a ventilator, the goal is to keep SpO2 is 88 to 95%. Our goal is to keep SpO2 is 88 to 95%. PaO2 is in between 55 to 80%. When using a ventilator, prolonged FiO2 more than 60% are associated with increased oxygen toxicity. This level is very high yield. So our target is to keep the ventilator 88 to 95% and PaO2 is 55 to 80%. And if we keep fraction of inspired oxygen more than 60%, it can cause oxygen toxicity. Thus, it is usually preferable to increase PEEP to allow for lower levels of FiO2 if oxygenation needs to be increased. Oxygen is changed with altering FiO2 or PEEP. So oxygen is changed with altering FiO2 or PEEP. Carbon dioxide is changed with tidal volume or respiratory rate. So oxygen is changed with altering FiO2 or PEEP, and the carbon dioxide is changed with tidal volume or respiratory rate. In general population, tidal volume in a mechanically ventilated patient should be 6 to 8 ml per kg of the ideal body weight. Like in 70 kg, 70 into 6, like 70 into 6. So looks like tidal volume should be kept in 420. Okay. PEEP, positive end expiratory pressure. Ventilator setting that can be chosen to increase the FRC by reducing alveolar collapse. Positive pressure 5 mm of water in the lung is maintained over the entire inhalation and expiration phases. Mechanism: PEEP increases alveolar pressure and alveolar volume. Collapsed or unstable alveoli reopen, improves ventilation perfusion relation, and it also provides an adequate PaO2. PEEP provides an adequate PaO2 at a low and the safe concentration of the oxygen, less than 60%. Less than 60%. Okay, advantage. Advantages of PEEP is avoidance of atelectasis, increased oxygenation, increased gas exchange area, functional residual capacity, and increased pulmonary compliance. Complication of PEEP is barotrauma. Typically involves worsening of the shortness of breath. Typically involves worsening of the shortness of breath. Okay. Complications of PEEP like barotrauma typically involves worsening shortness of breath after PEEP has been given to the patient, and pneumothorax suspect if the patient becomes hypotensive and mediastinal shift, tracheal deviation. Diagnosed with chest x-ray, and treatment with needle decompression can be secondary to barotrauma. So this is the two complication can happen due to PEEP: barotrauma and pneumothorax. Okay, now non-invasive positive pressure ventilation. Non-invasive positive pressure ventilation. Indication is COPD. COPD, severe exacerbation, prevent extubation failure. COPD, cardiogenic pulmonary edema, acute respiratory failure, postoperative acute respiratory failure, postoperative hypoxemic respiratory failure, immunosuppressed patient, and facilitate early extubation. So non-invasive positive pressure ventilation COPD is the number one cause, then cardiogenic pulmonary edema, acute respiratory failure, and facilitate early extubation. And contraindication when in a non-invasive positive pressure ventilation cannot be given if there is medical instability, cardiac or respiratory arrest or impending arrest, if pH is less than 7.1, if there is ARDS, acute respiratory distress syndrome, if there is GI bleed, if inability to protect airways, like uncooperative or agitated, if there is mechanical issues like recent esophageal anastomosis, facial or neurologic surgery deformity, and if there is upper airway obstruction. So again, non-invasive positive pressure ventilation. In a non-invasive positive pressure ventilation, the causes are COPD, cardiogenic pulmonary edema, COPD, cardiogenic pulmonary edema, if there is any acute respiratory failure, and facilitated early extubation. And contraindication is arrest, cardiac or respiratory arrest, severe respiratory acidosis, ARDS, GI bleed, inability to protect airway, and mechanical issue. Salmonid patient or coma, inability to protect airway, intubation should be done. Okay, positive pressure mechanical ventilation. Positive pressure mechanical ventilation causes an acute increase in intrathoracic pressure, causes an acute increase in intrathoracic pressure in the setting of decreased central venous pressure. In the setting of decreased central venous pressure, hypovolemic shock, these can cause acute loss of right ventricular preload with resultant sudden cardiac death. In the setting of decreased central venous pressure, hypovolemic shock, these can cause acute right ventricular preload with resultant cardiogenic shock. Continuous positive airway pressure CPAP predisposes users to recurrent epistaxis because of its drying effect of the nasal mucosa. So CPAP can cause recurrent epistaxis because of the drying effect of the nasal mucosa. Humidification is effective in preventing CPAP associated epistaxis. So humidifier is for preventing the epistaxis. Okay, now look at this box, effects of positive pressure ventilation in cardiogenic pulmonary edema. In cardiogenic pulmonary edema, in here there is increased intrathoracic pressure. In cardiogenic pulmonary edema, increase intrathoracic pressure, which will decrease right ventricular preload and increase right ventricular afterload. Decrease right ventricular preload and increase right ventricular afterload, thus decreasing the left ventricular preload, and left ventricular decrease left ventricular preload will increase the left ventricular performance. And in here, like the right hand side, there is decreased mean arterial pressure and decreased left ventricular transmural pressure gradient, which will decrease. So preload is decreasing, afterload is decreasing, which will increase the left ventricular performance. Increasing the left ventricular performance, increase cardiac output, and increase end organ oxygen delivery, increase end organ oxygen delivery and survival, end organ oxygen delivery and survival. And increased left ventricular performance will increase the PaO2 increase PaO2, arterial partial pressure of oxygen, arterial partial pressure of oxygen, and finally increase cardiac output and increase PaO2 will increase end organ oxygen delivery, increase end organ oxygen delivery and survival, increase end organ oxygen delivery and survival. An endotracheal tube that is advanced too far will preferentially enter into the right mainstream bronchus, causes asymmetric chest expansion and markedly decreased breath sound on the left side. So endotracheal tube that is advanced too far will preferentially enter into the right mainstem bronchus. So more air will go in the right. So there is decreased breath sound on the left. Ideal positioning is 6 centimeter above the 2 to 6 centimeter above the carina. It should be 2 to 6 centimeter above the carina. The initial criteria for extubation readiness, is pH is more than 7.5. pH is more than 7.5. Adequate oxygenation PaO2 is more than 60. On minimal support like fraction of inspired oxygen less than 40%, fraction of inspired oxygen less than 40%, and PEEP is less or equal 5, and intact inspiratory effort and sustained mental alertness to protect the airway. So three things should be in consideration for extubation of a patient. pH should be more than 7.25, and adequate oxygenation PaO2 is more than 60 millimeter of mercury on minimal support, and FiO2 minimal support like FiO2 is less than 40% and PEEP is less than 5 centimeter of water. Okay, intact inspiratory effort and sufficient mental alertness to protect airways, because there is a short-term risk of recurrent respiratory failure requiring reintubation. Most patients who meet the above criteria should undergo spontaneous breathing trial to help to confirm readiness for extubation. During an SBT, patients remain intubated but ventilator support is turned off. Candidacy for a successful extubation may be further assessed during SBT using these rapid shallow breathing technique, rapid shallow breathing index, which is calculated by dividing the respiratory rate by tidal volume. So if high rapid shallow breathing index is more than 105 and breathing fast and shallow are unlikely to do well without continued ventilatory support. So this rapid shallow breathing index is calculated by respiratory rate by tidal volume is calculated by dividing the respiratory rate by tidal volume. So for rapid shallow breathing index, respiratory rate divided by tidal volume. If it is more than 105, that means weaning failure is predicted. If it is less than 105, successful weaning is possible. Because endotracheal tube can damage the larynx and upper trachea over time, tracheal stenosis can happen. Tracheostomy is indicated when prolonged intubation for more than 7 to 10 days is required. Mechanical ventilation can lead to respiratory muscle atrophy and insufficiency, and exercise such as physiotherapy, coughing and repositioning, sitting and moving improve can respiratory insufficiency after mechanical ventilation. Okay, okay, look at this question. This 68-year-old man is admitted to the ICU 5 days ago due to septic shock, respiratory failure from pneumonia. The patient has been treated with IV fluid, vasopressor, broad spectrum antibiotic, intubation with mechanical ventilation. Now, strep pneumonia antibiotic have been tailored based on the sensitivity. Vasopressor has been weaned off and the sedation has been held. Current ventilator setting, tidal volume 488 ml per kg. If IO2 is 35%, less than 40%. Less than 40%. PP is 5, less or equal 5. Temperature is normal. Okay, now physical examination, there the patient is awake with endotracheal uh, tube is adequate position. He answered questions with head nodding and follow simple commands, such as to lift his head off the pillow. Lung auscultation show right sided crackle. Okay, now pH is leukocyte is 10,000. ABG show pH is 7.45. PCO2 is 35 and PO2 is 85. Sorry, PO2 is 82%. Which of the following is the appropriate uh, next step in the management? According to our discussion, he follows some criteria, like his PEEP is near about 5 millimeter of mercury, and he is awake and response. He's awake and response. Okay. Mm, so before jumping into the extubation, we need to do some SBT, spontaneous breathing trial. After the trial, we can assure that he is able to tolerate without ventilator. Later, he is able to tolerate without ventilator because intubation can cause respiratory failure. Okay, so perform SBT, spontaneous breathing trial. So mechanical ventilation, certain it fulfills certain criteria. pH is more than 7.25, which is more pH is more than 7.25, and adequate oxygenation. PO2 is more than, look, PaO2 PaO2 is more than 60% PaO2, and FiO2 is less than 40%. FiO2 is less than 40%. PEEP is less or equal 5, and intake is inspiratory effort and sufficient mental alertness to protect the airway. So our goal is to do SBT, spontaneous breathing trial, to help to confirm readiness for extubation. During an SBT, patient remains intubated, but the ventilator support is turned off, and it should be done for 1 to 2 hours. If this patient is ready for SBT, as is alert, so has normal arterial blood gas on minimal ventilator setting. Okay, these are the normal ventilator parameter. PaO2 is less than 80 to 100, PCO2 35 to 45, bicarbonate 22 to 26, and SO2 is 95 to 99%. Okay. Okay, finally look at this question. A 40-year-old man is intubated with receiving mechanical ventilation after being found unresponsive on the floor on his apartment. This patient is sedated and initiates no spontaneous breaths. The ventilator triggers 14 breaths per minute, okay, delivering 500 ml of tidal volume. Because of difficulty in ventilating the patient's airway, an inspiratory hold maneuver is performed to further evaluate his respiratory mechanics. During this maneuver, the ventilator is paused for 2 seconds. After entire tidal volume is delivered, the pressure The pressure at the mouthpiece is measured when there is no flow and is found elevated. Okay, pressure. This is the pressure. This is the hold, and this is the time. And in here, pressure measurement is done. The measured pressure most likely reflects respiratory system compliance. Why? 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 Okay. Evaluation of high peak airway pressure. This is pressure, this is time, this is normal pressure. Inspiratory by hold, inspiratory by hold. This is um peak to plateau, normally less than 30 centimeter of water. Peak plateau, normally less than 30 centimeter of water. And if there is high peak due to increased plateau, high peak due to increased plateau, it may be due to decreased respiratory compliance. Decreased respiratory compliance like PAP, pulmonary edema, abdominal compartment syndrome, and pneumothorax, where you will get high peak and high plateau, high peak and high plateau. If high peak but normal plateau, high peak but normal plateau, it may be due to increased airway resistance, that is BBM, like biting the endotracheal tube, bronchospasm, and mucus plugging. When tidal volume is delivered by the ventilator, the resultant pressurization of the lungs has two components. Pressure generated due to friction, pressure generated due to friction as the tidal breath flows through the conducting airways. Endotracheal tube in the terminal bronchial is called restrictive pressure and occurs during flow. An increase in the pressure indicates a problem. An increase in the pressure indicates a problem with increased airway resistance such as mucus plugging and bronchospasm. Pressure needed to distend Pressure needed to distend the lung by a given tidal volume is called elastic pressure. An increase in the pressure indicates a problem with a decreased respiratory system compliance, such as pulmonary edema, abdominal compartment syndrome. These two pressure, like restrictive pressure and elastic pressure components, are commonly summed together through the respiratory cycle. Total pressure equal to restrictive plus elastic pressure. However, they can be separated by pausing the ventilator momentarily after a tidal volume is delivered. The inspirator hold maneuver eliminates flow. Restrictive component is zero. Restrictive component is zero. Isotonic, isolating the elastic component. The resultant flat segment in the pressure tracing is called plateau pressure and reflects elastic pressure. This plateau pressure reflects elastic pressure. This plateau pressure reflects elastic pressure. Okay, the inspirator hold maneuver localizes a problem where mechanical ventilation becomes difficult. When mechanical ventilation becomes difficult, like high pressure alarm. If the plateau pressure is normal, if the plateau elastic pressure is normal, the culprit is increased airway resistance, bronchospasm. If the plateau pressure is elevated, the culprit is decreased respiratory system compliance. Decrease. If the plateau pressure is normal, if the in here plateau pressure is normal, if the plateau sorry in here the plateau pressure mm, looks like plateau pressure is slightly elevated, so looks like in this system plateau pressure is slightly elevated, so it looks like respiratory system compliance. It looks like if plateau pressure is elevated, the culprit is decreased respiratory compliance, like pulmonary edema. And if the plateau pressure is normal, plateau pressure is normal, it is the culprit is increased airway resistance, increased airway resistance. Okay, so airway pressure is the sum of the restrictive component created by flow through the airways and elastic component needed to distend the lungs by the given tidal volume is created. An inspirator hold maneuver eliminates flow and isolates the elastic component known as plateau pressure. High plateau pressure indicates poor respiratory compliance, and low plateau pressure, high respiratory and normal plateau pressure uh, indicates increased airway resistance. So for PR, if plateau pressure is raised or elevated, our respiratory compliance, their culprit is respiratory compliance, decreased respiratory compliance. So PR and like NA, like if plateau pressure is normal, then it is increased airway resistance, increased airway resistance. So that's all about the mechanical ventilation. And regarding question, this is a very complex topic. Hope you enjoyed.